Good afternoon, everyone. How are all of you doing?
I don't worry.
This is between you and your children, or you and food, or you in your hotel room. So hopefully this will be hopefully it'll be exciting enough, but quick enough for you to get to your next round of things that you want to do. It's a pleasure to be with you. I'm Lori Carter-Edwards. I am the Associate Dean for Community Engagement and Government Affairs, new role this past May at the Kaiser Permanente and R.J. Tyson School of Medicine. And Colleen has asked me to talk with you about just what is diversity and how engagement plays a role in that. So I'm going to try to talk with you about that for a few minutes, and then we're going to open up the floor for you in the latter 30 minutes. So I'm looking forward to hearing what you have to say. Be prepared. I'm going to add 3 different polls for you. So when the screen comes up, go ahead and either, if you're on your computers, put in the link to Poll Everywhere and put in my name, Lori Carter-Edwards 188. You'll get ready to see it. Or if you're using your phone, you'll put in 23222, or you'll see it when it comes up, and then put in Lori Carter-Edwards 188, and you'll be able to participate in these 3 different polls throughout. So I'm just forewarning you when they come up, if you do have your smartphones or your computers. I want to give a few caveats because this is new for me. Engagement is something I talk about in general, locally and nationally, but I am new to your world, and I'm just honored and graced by Colleen inviting me. And I do not take that lightly, nor do I take it for granted. So my caveats are basically, forgive me if I say anything that does not make any sense, or let's we all work together. But seriously, we all are we are greater than our sum of our parts. And you've heard a lot today, and I've heard a lot today about how the variation and the similarities we have with each other. So just to keep that in mind as we talk about diversity, we have life stories that we should respect, and diversity is not a noun. It's listed as a noun in Oxford Dictionary, but it really is an active word that we need to be thinking about across the board with all the different populations that represent diversity. And how we balance that with making decisions. So while we are diverse, and Stephanie mentioned this, we still have some common goal. And we may generate more questions than concerns, and all of this starts from within. So what I want to do is I'm going to hopefully be able to convince you that diversity is a dynamic, evolving construct. We're going to understand community engagement and how it applies to research, which is the work that I typically do, and identify some engagement strategies that you can use to increase diversity in both the association, IMDSA, and also within the community of research. So here's the first survey. And I'm going to go in so you can see it, but here, what do you think of the word, when you think of the word diversity, what one word or brief phrase comes to mind? So you can go to pollev.com/Lori Carter-Edwards 188, or via text, you'll respond to 2333 with Lori Carter-Edwards 188. I'm going to go to the poll so you can see what you're saying. See if I do this right. Here we go. Okay. I think hopefully I've made it active. Let's see, activate. So what word, when you think of the word diversity, what one word or brief phrase comes to mind?
One more time, Lori Carter-Edwards.
188. And you can see it's right up here too. Can you see it up there? Oh, I'm sorry. So yeah, once you put in, if you're using your phone, once you put in 22333, put in Lori Carter-Edwards 188, and it's LORI Carter-Edwards. Words are popping up. When you think of the word diversity, inclusion, mosaic, richness. The larger the word, for those of you who have not been exposed to word clouds, the more frequently that word is being mentioned by you. Differences, representation, stronger, I like the us. This is great. Variation, needed, culture. Inclusion and representation are the ones that are popping up more. We'll keep this up for a few seconds more. This is you telling your story of what diversity means. And you've been hearing a lot in the news. You hear a lot about different offices, diversity, equity, and inclusion. It means different things to different people. You have to define it for yourself, but I'm going to talk about, after this slide, talk about what's in the literature about the term diversity. These are great. Last call, and I'll save this for you. Anyone else? Cool. So think about that as we keep moving on. Love it. Inclusion, representation, differences in everyone are the ones that are most frequently mentioned. And then we have this beautiful mosaic, all puns intended, of other words that are listed here. So this is great. I'm going to go back to my slide deck. Okay, and let's see. Thank you so much for that. So I'm going to talk about what diversity is, what is it, and why does it matter? The Oxford Dictionary gives these definitions: the state of being diverse, variety. It is a noun, of course, as I mentioned earlier, but the practice and quality, even though it is a noun, it's an active noun. The practice and quality of including or involving people from a range of different backgrounds. There's a blog that talks about workplace diversity and lists like 5 different types of workplace diversity. And you see there it's cultural, racial, gender, physical disabilities, and personal interests. They don't, in physical disabilities, they talk about the traditional disabilities that we talk about, but it does not include typically mental health and what's in the literature in terms of the work environment. But I'll talk a little bit more about that later, where there is a push to really understand this in a work environment for those with Down syndrome. But this is just to get us started to think about these different ways that workplace diversity is complex. There are layers to what this is, and not just what you typically hear in the news, where it's typically frequently referenced as race, when that's not necessarily always the case. That we're a diverse country, we're a diverse group of people, we're a diverse group here within this association. Diversity in mental health often is referred to this intersection of race and culture and socioeconomic status, but it usually is not talking about diversity of mental health condition in the literature. It also talks about, when it talks about mental health and diversities, usually the outcome from the diverse event. So how someone is treated and then their outcome that relates to some mental health. So depression or anger or stress. Those are the ways that mental health is referenced, not in the way that we would think about it here. And so that's what's basically more so in the literature. And then for mental diversity is a term that's also out there, where there's a framework that is considered controversial, neurodiversity. And this term came from this related word by Judy Singer. She's an Australian sociologist who coined the word neurodiversity in 1998 to recognize that everyone's brain develops in a unique way. The term describes people whose brain differences affect how their brain works. And this means that they have different strengths and challenges from people whose brains don't have those differences. And there are possible differences, including medical disorders, learning disabilities, and other conditions. Experts research also shows that words and language related to neurodiversity make a difference in how people live. People who are neurodivergent and learn from that, it means that they're different, not sick or defective, and more likely to be happier and aim higher, at their careers. There are many things that people can do in support of neurodivergent individuals. And I'm trying to pull this up. Sorry for this. I'm still learning. Okay, forgive me. Well, I'm gonna keep talking about this. So in this mental diversity with the concept of neurodiversity, the reason it's considered controversial is that some believe that it does not account for possible needs for treatment, or the other, it's a negative view of what's not being covered by those who were considered neurodivergent. However, neurodivergent is supposed to be a positive term. And I don't know how many of you've heard the term neurodivergent. Okay, so if you have heard about this, forgive me. I don't want to educate the room if you already know a lot about this. But what's interesting to me when I was looking at how to describe diversity is that there are accommodations that exist for physical and sensory needs in the workforce and in schools for those who are neurodivergent, and that the supportive behaviors and actions of others can be implemented. And so this is another definition that defines diversity, at least in the mental health arena. When we think about diversity in rare disease, Laura Elisiu with ICON, which is a CRO, or a clinical research organization that basically does research for drug studies. She says that the importance of diversity, equity, and inclusion is arguably even greater within rare disease, as clinical trials have the immense promise in the patient journey compared to common conditions where multiple treatment options often exist, but diverse communities are still underrepresented in rare disease clinical trials. And that the goal in rare disease and clinical research is to include as many people with a particular disease from diverse backgrounds as possible in order to understand and treat it. And this will drive increased understanding and progress. And many of you who do this research on a regular basis know that there are plenty of studies that are going on now to try to increase the opportunity to understand rare diseases, such as the All of Us study, and others that are being done across the country. What you mentioned in terms of barriers that need to be addressed is along this path of stakeholders, where there's the patients as well as the clinicians and researchers. And you see these levels of barriers. So there are data limitations that come out with rare disease and diversity, and trying to understand diversity in rare diseases. There are common outcome measures that don't exist, that we're still building, and we've heard a lot about this today, just even from the biomedical arena. A limited pool of principal investigators who actually represent the populations that we're actually trying to understand, and then a lack of patient advocacy organization support. When I looked at this seemed like you're thinking that the patient advocacy group is unaware, but the reality may be that there's been a lack of a mechanism to involve you as patients and as family members in this arena in a formal manner. We know that we have IMDSA, but there are also other opportunities to actually make this even more and have more opportunities for more association groups to include patients, which in the fields that I work in, which is cardiovascular disease and also in stroke, we have groups, but often the patients aren't involved in the research arena. And there used to be, even at NIH, used to be a group that involved patients that was eliminated. And they're hoping to actually create that again for all kinds of studies at the National Institutes of Health, called COPPER. And I can't remember what it always stands for, but I think it stands for Patient Council on Patient Participant Representation. Norman Goldfarb talks about diversity and gives reasons for why we need to increase this in clinical trials. And we've heard a lot of this already today: commercial, therapeutic, to share burdens and benefits fairly, and to support underserved populations and access a larger population, which you've heard. He also gives these 12 questions. I won't read them here, but why we need to answer to achieve diversity in clinical research. And you can see those questions there. We talk about this word, and we've been throwing it around a lot lately, but we really don't think about this and what it actually means. What do we need to do to understand how to really unpack it for our own purposes to do the work that we need to do? And you'll see the questions that are listed there. And he lists 12 really good questions that are provocative and also ones that we should be thinking about as we try to understand the benefit of diversity in the work that we do. And it could also be for the association and for the study of Down syndrome. We know that everything that we've been talking about, and I don't know how much you've been thinking of intersectionality. Have you been talking about intersectionality? Does everybody know? Okay. So anybody not know what I'm talking about when I talk about intersectionality? Okay. So intersectionality basically means that it's not just one factor that influences the outcome, but there are multiple factors that influence an outcome. So it's intersected by these big groups of things. So for instance, if I had hypertension, I may have hypertension because I may be a Black female overweight, but it may also be that I have predisposed because of genetics. It may also be because of the environment that I'm exposed to. So those things together, the intersectionality of those increase my risk for actually having the condition. And so when we talk about diversity, diversity is not a simple term. The whole point of this slide is to demonstrate how complex diversity is. And we often talk about it in mostly where you see the red dot. That's where most of the research has been done in the intersectionality, the two intersections of culture, race, gender, age, disability, economic diversity, and mental health diversity. So what I just mentioned, where you have outcomes that are related to being treated a certain way, people feel stressed, that intersection may be the reason why someone's at greater risk in that group. And that's the group that most of the studies have been done that I've seen. So this is basically me just looking at what I've seen in the literature. The other one, the one with the orange dot, is where the rare disease intersects with culture, race, gender, age, disability, and economic diversity. And these have mainly been in historically majority populations, primarily those who have been higher socioeconomic status, those who may not be from diverse racial or cultural different backgrounds. And so those are where rare diseases have mainly been studied for those particular groups. And so that's another group that has been studied more than the group that's in the yellow, which I'll mention last. In the purple, there's the rare disease diversity and mental health diversity, and that overlap. There's now been more established research for some rare diseases and mental health, which you've already heard about today, and more than others, but they may not intentionally account for culture, race, gender, or the other factors that are in the green circle that's on the bottom left. But the rare, possibly most difficult group to reach, but still extremely important to embrace and understand, and their efforts to engage multiple sectors and stakeholders is critical. And so one of the things Colleen had mentioned to me is that some groups are not at the table, but they may have mosaic Down syndrome, like a Latina population that's listed here, or some other population. It may be some other group, but the convergence of these actually is the intersection of diversity that we aren't really able to study because we don't have the populations. They're hard to reach. And so just think about these things as we think about intersectionality and where the research lay. The power of community to create health is far greater than any physician, clinic, or hospital. So your community is why this happens and why you're able to move forward, mentioned by Mark Hyman. The work I do is in community engagement, which is really an approach. And it's where there's groups of people who work together. And I use a lot of tools, do a lot of community engaged research. Didn't bring it up here because that wasn't the scope of this presentation. But typically this is the umbrella of community-based participatory research, community-based partnered research. You'll hear those things. This is an approach. It doesn't necessarily mean it's going to lead to research. It's about building relationships. And there's strategies that we use to build relationships. However, stakeholder engagement does have a purpose. And stakeholder engagement is actually trying to address some issue where you're actually trying to develop a policy or program, and it's usually ongoing. And the expertise coming from you as parents, patients, is just as important as those of us who do the research. And so we're trying to do a better job of basically bringing the expertise to the table. So one of the institutions that we collaborate with has community faculty. These are people who have not gotten PhDs or MDs, but they're community faculty because they're experts in their community, and they have been brought into the academic system to try to improve how we ask questions, how we design studies, and they play a critical role with the faculty that actually do have been trained in the research, the traditional research. I'm listing these are 9 principles of community engagement that come out through NIH. And these principles are critical to how we do our work. And like I said, there are 9 of them. This was put out back originally in 1998, and then again in 2011. And now the third round of the principles of community engagement it's taken a while for them to get out, but the only thing that's been added there is trustworthiness. And the difference between trustworthiness and trust is trustworthiness is the responsibility of the person who is asking for the trust, versus building trust, which leaves the premise on me as a researcher. The onus ends up being on you as the patient, or you as the parent in the research that we do. So I'm up here trying to do something so that you can do something for me. Trustworthiness is me demonstrating I'm trustworthy enough for you to even engage with me. And I'm not looking for something in return. It's me actually demonstrating that I'm trustworthy enough to even be in your space. And this is a very different way we're doing research. I'll share with you in a second what I've been working on with the National Academy of Medicine, of going from practice to research so that we can try to build the relationships and then move forward to actually work together better, because the issue is about trustworthiness that I demonstrate in order to partner. These other ones that you see, be clear about the goals, become knowledgeable. Collective self-determinism is you as the patient or the community member, you're the one who defines what matters, not us as researchers. And that's a bigger shift than what we typically do. You would actually define, and you're doing this now with being members of the association. Partnering, recognizing and respecting the community's diversity. Identify and mobilize assets. In the way we're all trained in public health or in medicine, we're trained typically from a deficit framework. So we're actually always looking to try to improve what has happened wrong. And I think Stephanie made the comment about going from trying to preempt situations. And so when you identify community assets, we have asset framing, asset mapping. There are a lot of different strategies where we figure out what works for you, and then we replicate that rather than looking for what's wrong. It's a different lens. And in communities that may be the most desolate and have the most issues, somebody's doing something that they're still alive and living well in some capacity. We don't know how to think about that on a regular basis to then take that approach and replicate that. So it doesn't mean that they have to look like what I want them to look like in my community, but in that community, what does resilience look like? What does resilience look like for you as a patient or a mother who has 2 children that have Down syndrome? What does your resilience look like that we can replicate that rather than what the problem is that we're trying to solve? And then committing and preparing to release control to the community, which is very difficult for those of us who are researchers. Often we will come up with the design rather than talking to you first and seeing what you want to do. And so sometimes we have to release the control. I have a project where after I started to work with the community, the pastors went and met without me. I brought them together. They don't need to be there. They're basically taking what I showed them and they're building their own capacity. And they went from 17 churches to 118 churches in 18 months, and they run their own thing. That's releasing control and doing what I need to do and then leaving and respecting them and their power, right? This has come out recently in February of last year, and I'll move quickly with this, but the link is, you'll get these slides. But the National Academy of Medicine had a series of colleagues to try to understand how to assess meaningful community engagement. We've had a really difficult time to try to come up with measures of what it means to actually assess community engagement. And so a series of researchers and community partners across the country came up with this framework and these 4 domains: strengthening partnerships and alliance, expanding knowledge, improving health and healthcare programs and policies, and thriving communities are the 4 domains that they saw, along with all these other measures that are within these, are ways to assess meaningful community engagement. And then they had a series of impact stories to try to demonstrate that. And my colleague and I are one of those 7 impact stories that you can find on the link as well. Let's go to the second one, which is second poll. Which 3 community engagement principles matter most to you when you think of ways to advance Mosaic's Down syndrome research? I'm going to go to the question. Let's see. Okay. Here's the question. If you just want to choose one, you could choose one. What matters to you most? Of course, all 9 may be useful to you, but what resonates with you? There are 2 that resonate with me heavily. And so I typically pick those when I train my students. Which ones matter the most? You'll be able to pick 3. And I'll give you this too. The reason this is important to do, because this will drive some of the work that you choose to do moving forward, because these are the factors that will be the measures that you can work with researchers and patients together. And we're seeing recognizing, respecting community diversity. And we don't know what that may mean for you, and that's something that hopefully you can share in this after I finish, when you as self-advocates talk and share what you think is needed in research. The other one that's more frequent is commit again, and then knowledge and trust so far. What's interesting too is that these terms, we throw them around and they're like, why is anybody even studying these things? They're not easy to measure. They're not 1 + 1 = 2. They're not math. They're not lab. Why do we even do this? We do this because some of us who do this research have found that some of these factors actually make a difference. There's an association with these particular constructs and how it impacts participation in research studies. They're associated with some outcomes remotely. Some of these may be associated with even partnerships or how research may even be conducted. I participated, and when I was back at I just moved here 2 years ago from North Carolina. I was a professor at UNC Chapel Hill, and I moved back to California, where I was born and raised, Los Angeles, to be close to my parents who are in their 80s now. And when I was at UNC, just to give you an example of the power of the community, we had one professor in the department I came from. I was in the Department of Epidemiology, and I was also in public health leadership. And this one researcher who didn't understand meant well, went into the community and told the community what they needed to do. The damage was so bad that all of us who worked in that county, damage control had to be made, because all the other studies that were being done in that county almost halted, because everybody in the county talked about what happened, and they ended up not trusting the entity. It wasn't just the individual. They didn't trust UNC Chapel Hill after that. So we're having to do damage control just to get people to participate again in all the other 5 or 6 major studies that were going on in the county, just because of one investigator. No call, it's not about calling her out, it's about to mention how one person can lose the trust of a community that fast. And that's why these things matter. So it's great. You guys basically said recognize and respect. And this is really important, so that when we need to think about how to impact that, when I give this over and you think about this further. So thank you so much for completing that survey. I'm going to go back to the slides. Okay. And okay, great. I'm going to go through the rest of these quickly. If you want to lift yourself up, lift someone else up, and collaboration allows us to know more than we are capable of knowing ourselves. I know these seem like common, but sometimes it's great to have these phrases to be thinking about and remind ourselves of them. So lastly, I'll just have a few more slides and then want to hear from you, but engagement strategies to promote diversity. How many of you have heard of active listening? Not just listening, but know what active listening is. Great. Okay, so we know active listening and knowing how to basically parrot back what you're hearing, because we could do the telephone, and by the time I talk to you, say, hi, how you doing? By the time we get around to you, I'm basically you're saying, the cow jumped over the moon, huh? Right? Share what you learn with community members and researchers. Talk about this, and you're already doing that. And this is really powerful, because it then gets buy-in, and it's a way to start the process for consensus. Connect with new organizations whose missions and visions include understanding and promoting diversity. So I found out about the Rare Disease Diversity Coalition, where they try to eliminate health disparities for rare disease using a suite of advocacy tools for researchers, clinicians, and for patients and families to try to educate about rare diseases. It's actually pretty nice set of tools that I've seen on this website, and those of you who've not seen it before. Learn about engagement strategies in other areas and see how they may apply to supporting research that you're doing. So for instance, in this next slide that I'm about to show you is what I was telling you about. This is tied to that big figure that I mentioned to you, where assessing meaningful community engagement. These impact stories are the next level of that. And so our work demonstrate examples of the way to actually assess meaningful engagement. Mine talked about partnerships. It's lower down in here, and I worked with developing a faith-based network, which I mentioned to you, went from 17 churches to 118. And then you see the other studies there. So if you go to this website, you'll see these stories, and you can download the PDF and look at how they're doing this work, and then see what makes sense to actually use or replicate or modify for your purposes. Collaborate with experts in community engaged research. There are a variety of tools that I use. I'm still a member of UNC's Clinical Translational Science Institute. Harvard has one as well. There's 60 in the country. I'm the co-chair for the National Diversity, Equity, Inclusion, and Accessibility Enterprise Committee for these institutes. And there are 5 of these standing committees with these groups nationally. And so we use a lot of tools. We talk about this work. There are a variety of ways to bring people together. There are ways to do town halls. There are ways to do stakeholder power analysis and mapping. I use a tool called the Give-Get Grid that allows you to talk with someone to find out what they want to do and what they're planning to bring to the table, and how you use that starts this dialogue to then list action plans for how you're going to work together. There are a variety of ways to do this, and some people are training them. Sometimes you can look for them online, but there are those of us who do this on a regular basis, and we provide these services to others. Resources to help align values around diversity. So training workshops, implicit bias workshops. How many of you have been to an implicit bias workshop? Okay, just a few. How many of you have an implicit bias? Everybody should be raising their hand, because then when you make a decision to drive the car and you're looking at something else, you make a judgment call. Judgments we make every single day. There's nothing wrong with having a bias. What it is if you have an implicit bias that impacts someone else. And so this is why it's really good if you can get a chance to participate in implicit bias training. And then there are leadership trainings like adaptive leadership. How many of you know about adaptive leadership? Okay, yep, those are hybrids, right? So trust opens new and unimagined possibilities. So diversity is complex, it's dynamic, it involves action. The intersectionality of rare diseases, mental health, and these other factors is a space where strategies for engaging these populations is critical for doing the research that you will do. Community engagement principles are fundamental for building relationships, and evidence-based and practice-based individual and organizational strategies to promote diversity can serve as a guide to advance this body of research. And you saw some of those strategies were individual level, and some of them were organizational level. And so these are things to be thinking about as you move forward. So this is the last one, last survey, and then want to hear you talk, and we'll be done in about 10 minutes. So if you could choose one word or brief phrase to describe what you would like to see in mosaic Down syndrome research, it would be to see what? Okay. Okay. If you could choose one word or brief phrase to describe what you would like to see in mosaic Down syndrome research, it would be to see what? I could have worded the question better, so those of you who know that this is poorly worded, just forgive me. But okay. You're seeing participation and inclusion. You have to define what that is. Hopefully some of you will be willing to share that right after we do this survey. Improvement, interventions, self-advocacy. Friends, I'm not sure what the ... is, but I will share that with Colleen once we finish. It'll be interesting to see what that is completely. Or someone who's mentioned that can share it. Worldwide. Interesting. We like to see menopause. Hopefully someone will be willing to share that. Self-advocacy. Betweeners. Interesting. I call people bridgers. We spend more time, no one should be expected to be in a camp that they're not in. We should be building people's capacity who are the bridges between different groups of people. That in and of itself is its own workforce. That may not have been what somebody meant by betweeners, but I think about the word bridgers. Okay, inclusion, engagement, employment, indeed, voice, friends. I'll stop it in a few seconds. This is wonderful. Diagnosis, generalized. Comorbid, fertility. See results. One of the things in translational science that we still need to spend more time working on when we go from conceptualization and design to implementation to results and dissemination. While we're asked in NIH grants or expected to talk about a dissemination plan, we really don't spend a lot of time on dissemination and implementation unless it's a dissemination and implementation science study. And so we have to do a much better job of getting the information out to you while we're working on it before we go to the next grant. Or one of my colleagues and some of the tools that I have been developing, that I developed at UNC with some others, with community engagement or community academic partnerships, is after you participated or a principal investigator has submitted a grant, how many of you who have been participants in designing and submitting the grant as a community partner, how many of those investigators have had a debriefing immediately after submission? Not when you've heard whether you got the grant or not, but once the grant was submitted. How many of you participate in that? My colleague, who is the director of the Office of Sponsored Research, said that is the most critical space, is right after a grant is submitted. You as patients who are involved, if you were part of the advisory team that helped design and design the grant that goes out, need to be having meetings right after that to talk about what worked. If the grant gets funded, what are we going to do? So you're prepared once the notice of grant award comes through. Or if it doesn't get funded, what is something that you think you want to do to improve the process? That should be, those are strategic moves that you don't wait until you hear from the grant, and you need to be involved in that. So thanks for letting me get on my soapbox, because I do get on that soapbox big time. And basically having a kickoff meeting, not only with, if you're part of an organization that's working with an academic institution, but to have the business person at the table on the first day. Because that's where the big problems come, is that when community partners want to get paid and the business person who doesn't understand all the nuances, you end up with all the headaches later because the business person doesn't understand the project. So we have to do more of these kickoff meetings that then help out in that space. Awesome, you can keep doing it. I'm going to go ahead and I think I'll do this right. I'm gonna go back to this. So let's hear your thoughts in this next, we want to hear, oops, let me go here. Thanks for letting me go back and forth with all of these slides. Okay, so let's go here. This is our last slide. So I want to hear what your thoughts are and what you want to see in research. Now you've filled out this survey. You fill this out, okay, but this is your chance to share your thoughts. We've got about 5-7 minutes of what you think can be done. Those are 3 areas. If you look at the research continuum, we spend time conceptualizing and designing studies. And some of them may even be clinical trials, or some of them may be just general intervention. Some of them just may be observational studies, which for me as a cardiovascular social epidemiologist, I spend a lot of time doing those kinds of studies. Recruitment and research implementation. So once you've decided what you're going to do, what do you think needs to be done in the space of recruitment and actually implementing the study? What have you seen that's gone well? What have you seen that's not gone well? What do you think is important to bring more people in to the arena of mosaic Down syndrome? Okay. And the findings already talked about dissemination. So anybody want to share their thoughts? Yeah, you do. Yeah. She does. Did you say? Yeah. Yes. Mm-hmm.
Or anyone.
Anyone. Mm-hmm. But
Other mom friends that I tried to
I think that just then they ultimately chose not to. They just felt that it was invasive. There were concerns about time. So I think maybe just getting over some of those basic communication hurdles. Does that make sense?
totally.
We do participate, but that's some of the feedback I know I've gotten.
Would they be willing, that's their apprehension in participating in a trial, right? In a study like, or is it in anything? Would they be willing to
Anything.
in anything? So even to inquire what may be the fear that they have or what could be done differently, they wouldn't want to do that either. Like taking a step back from the study that's an intervention to just understanding what their thoughts are. Would they be willing to do that?
I didn't know.
Yeah.
They were pretty passionate. I let it go.
Mm-hmm. Sometimes this is about, remember when I was mentioning the difference between community engagement and stakeholder engagement? Community engagement is me not even wanting anything from you. It's just to get to know you and see what your interests are, not what my interests are. And sometimes we do a lot of qualitative studies to just even understand what you're interested in. And they could be private interviews, they could be small focus groups a focus group that you have with your friends and you be the spokesperson. So they're proxies. No, the data aren't as rigorous, but they get at the answers we're trying to get at using mixed methods is what we typically call it. So thanks for sharing. Yeah. Somebody else?
I just want to say I resonated with your concept of trusted messenger. And some of the research in our Down syndrome community shows right from the beginning, we lose the trust of our families, and how the diagnosis is delivered is often inaccurate, incomplete, and offensive. And families could oftentimes say, I remember when they told me this. And in some of our research, particularly of families who have loved ones with Down syndrome who identify as Black, African American, or mixed race, say even when their child is 13, 20, 30, they still have trauma-informed care based on that original mistrust. And I just, a lot of research still needs to go into how do we get it right in that first conversation, because it really does set the pace. And I think our difficulty in recruiting and inviting the rich diversity to our community comes right from the beginning diagnosis.
You hit the nail on the head. I've not had that experience in that fashion, but I've had a traumatizing situation where I lost my first child with placental previa. Then at 5 months, I had a hypoplastic left heart. So my daughter, because I did have a daughter, was missing her left ventricle. And I remember just hearing that she was going to have surgery the minute she was born, and then go to heart, have the heart with the Hemi Fontaine. I heard nothing else that was happening. And the reason I'm bringing my story up, because I remember how traumatizing that was. And the pediatric why am I saying it wrong? No, not the cardiologist, echocardiologist. Thank you. I had the wrong. You see I clearly was, I couldn't hear a word he said. My ex was there, and I just remembered every moment. I remember riding in the Duke tram to go for the second ultrasound to then see that she clearly didn't have that left ventricle. And I can't imagine what it must be like for those who are mistreated, the story we heard earlier. I think that what happens is that we don't train on this. What we're doing right now at Kaiser is we're trying to talk about that in terms of, with our health system science department, how to actually address this. And part of it is not asking the right question, because when somebody's not ready to hear it, you have to go to the next stage of asking the right question, because sometimes you miss a point. I published a paper that I'll share with Colleen called Comfort in the Arms of God. And it was a thought piece about a Black female being diagnosed with type 2 breast cancer. And she immediately says, when the doctor comes into the room, and this was illustrative, she said, I'm not claiming it. The doctor didn't know that was profound for him to actually unpack what that meant, because claiming it from a religious term could mean, I'm going to let God take care of all of it. I don't have to do anything, whatever. I don't have to go to the doctor because God's going to take care of it. That could mean claiming it. Or it can mean faith without works is dead, and I'm going to go and do whatever the doctor tells me, but I'm not going to claim this disease. I'm not going to let it take me. If the doctor had stopped to take the time to ask the question, you would know how to respond to that patient. I don't think we take the time to look at body language, or even not just sharing the diagnosis. How do we actually talk to people? And I don't think we spend a lot of time connecting with sociologists and psychologists to help us with that language more. Clearly, our institutions have been doing that to some degree, but to actually institutionalize that at a larger level, we have a lot of work to do. And that's where you as patients and parents have an opportunity to really work together. Some people do crowdsourcing. One of my colleagues is a pediatric gastroenterologist. He's gotten PCORI funding as well. Mike Kappelman, who you probably know. He created a crowdsourcing website where patients and families who are experiencing pediatric gastro symptoms, these parents were getting together, and then the researchers got a chance to see what they were interested in, and it included how to talk to a patient when they're hearing this kind of information. So there's something to be said about you galvanizing together and even potentially even identifying what matters to you and sharing that as a white paper or creating a white paper from this association on this is how we need to start thinking about communicating with patients, with parents and patients when they are being diagnosed.
So two things on this. One, Brian does bring up a good point. I do think implicit bias is part of it as well,
Totally.
especially for somebody who had to go through fertility treatment, because you go down that path and right away there's an immediate recommendation to exclude, chromosomally abnormal embryos. And so it's just, that's a problem. And then my second point is that fortunately here in San Diego, I have been very blessed to be able to participate with a whole group of moms who, when I gave birth to my child with mosaicism, there were other moms that were giving birth around the same time, and there's probably 20 of us on this list. And there's some strong advocates in that group who have been trying to go into our hospital environments here locally with feedback to the physicians as to how they speak to patients and new moms. And there is a closed door policy in terms of, acceptance of brochures, feedback from us. So I think it's got to be more of a partnership or a collaboration between parents and I will. There's another story that I'm not going to bore everyone with, but even in my own family where I have a sister who's a physician who has said something very deleterious about my child. I know it's not her personal feelings, it's the way that she was taught.
Mm-hmm.
And so there has to be a collaboration between there.
I wonder also if you have an advocate at, the hospital that you were talking. Yeah, there's one right here too. An advocate in the hospital. There's one thing to.
We do. There's a Down syndrome clinic here. So we have the moms, not this mom, but some of the moms who are way more advocate than I am, immediately called that physician and said, please help us distribute these pamphlets. So that if you are telling new moms prenatally that they have a child, with Down syndrome, that there is this local group of pregnant moms who are in your exact shoes. Let us interact with your patients, but they're saying, well, HIPAA's an issue, and so we can't pass that along.
But what could be done is when we talk about patient navigation, that could be a resource that is listed. So for instance, if you take a step back, one of the things could be that the small win, that's a big win, but the small win could conceivably be that you are working to get your resource online, as a resource. That's the first small win. And sometimes trying to figure out what those small wins are. It doesn't negate what I completely agree with you. It's just trying to think about all these different ways to be tactical. Mm-hmm. And you need to, mm-hmm. Yeah, go ahead. So do you want, not one more?
We've got, just
yes.
because I've got two self.
Yeah. Okay.
Two self-advocates who need to talk yet.
Yeah.
We have.
Oh, yes.
Yeah.
Thank you.